Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
It is great to be here.
Yeah, so picture this. A hypotensive trauma patient rolls through your bay doors. And the paramedics, they're beaming with pride because they managed to slam 2 liters of normal saline and normalize the blood pressure to a beautiful 120/80 during this frantic, 15-minute transport.
Right. A totally classic scenario.
Exactly. But instead of feeling relieved, you look at the monitor and you look at the whooping puncture wounds on the patient and you realize that, well, that successful transport just effectively killed your patient.
It's a terrifying realization.
It really is. So today we're basically taking a sledgehammer to the dogmas of pre-hospital care. Because as trauma and surgical critical care surgeons, you're used to controlling every single variable in the OR. You dictate the pace, you manage the instruments, you orchestrate the team.
You're the conductor.
Right. But the harsh reality is that the physiological trajectory of your patient is, well, it's very often set in stone long before they ever reach your sterile field.
Oh, absolutely.
What happens in the dirt, on the highway, or in the back of a moving ambulance essentially primes the physiological pump that you're going to be forced to manage for the next several hours in the OR, and honestly for the next several weeks in the surgical ICU.
Yeah, and we constantly see this in our morbidity and mortality conferences, right?
Okay.
The pre-hospital phase is frequently treated as this blind spot, like a highly stressful taxi ride that we just sort of accept as a precursor to the real medicine.
Just get them to me, right? That's the mindset.
Exactly. But the specific interventions performed or critically purposefully withheld during that transport window, they fundamentally alter the trauma triad of death at a cellular level.
Yeah.
I mean, the coagulopathy, the hypothermia, the acidosis, these cascades, they don't politely wait for the hospital doors to open.
They really don't.
And if we, as the receiving physicians, if we don't understand the raw data driving these field protocols, we're essentially beginning our surgical resuscitation blindfolded. We're trying to reverse damage that's already irreversible.
Which brings us to our core mission for this deep dive today. We are pulling excerpts from a foundational text. Specifically, it's the book chapter, Evolution of Modern Prehospital Trauma Care and Patient Outcomes by David V. Schatz and Kevin E. Mackey.
It's a fantastic chapter.
It is, and we are putting the most entrenched dogmas of pre-hospital care under the microscope. We're going to dissect these practices using hard data, tear apart the methodological limitations of the studies that either, support or condemn them, and extract evidence-based clinical pearls.
Pearls that directly apply to modern U.S. trauma systems.
Exactly. And the latest guidelines, like the American College of Surgeons ATLS 10 and the military's TCCC 2all19 updates.
And I think the critical evaluation of that methodology is really going to be our primary lens today. Because for decades, pre-hospital trauma protocols, they were not driven by prospective, randomized, or even highly powered observational data.
No, not at all.
They were driven by historical precedent, military anecdotes, and honestly just physiological assumptions.
Yeah, like, this makes sense on paper, so let's do it.
Right. We adopted practices because they logically made sense at a macro level, not because statistical analysis actually proved a survival benefit. But now we finally have the data density to challenge those core assumptions.
And some of those findings are deeply counterintuitive.
Very.
Okay, let's unpack this. Before we even touch the medical interventions, we have to look at the literal vehicle delivering the patient, right?
Yeah.
And the philosophy driving the accelerator pedal. We have to start with the concept that single-handedly built modern emergency medical services.
The big one.
I am talking, of course, about the golden hour.
Oh, man. It is arguably the most famous phrase in all of trauma surgery. And its origin story is really a masterclass in how a powerful narrative can just completely outpace empirical data.
Yeah, it really is.
The term was coined back in 1976 by Dr. R. Adams Cowley. He was the legendary pioneer of the Shock Trauma Center in Baltimore. And his much-quoted dogma was simple, it was terrifying, and it was brilliant. He basically said, there is a golden hour between life and death. If you are critically injured, you have less than 60 minutes to survive.
But I've always had a massive problem with that exact phrasing, Was Cowley's 1976 claim actually based on peer-reviewed science, or was it just brilliant marketing designed to secure legislative funding?
A lot of it was funding-driven, yeah.
Right, because he was trying to build a regional trauma system. And when you look back at his original publications, there was absolutely no robust scientific evidence to support a strict 60-minute physiological cliff. It didn't exist.
No, it didn't.
We essentially built this pizza delivery model of trauma care where speed became the singular overriding metric of success.
Hmm.
We incentivized lights and sirens, high-speed ground transport, incredibly aggressive helicopter use, all under the strict guise that minutes always equaled mortality.
Always.
But at what cost to the system?
Well, the cost has been measurable in blood, not just dollars. When you dive into the data regarding the morbidity and mortality of the actual providers and the public, the statistics are just staggering.
They're horrifying.
Right. So the golden hour concept was heavily influenced by the military experience, specifically the dust-off medevacs of the Vietnam War. Surgeons there noted an average of 1.04 hours for a wounded soldier to arrive at a surgical hospital.
Hence the hour.
Exactly.
Yeah.
But even in Vietnam, over a 2-year period, 39 crew members were killed, and 210 were wounded in unarmed medical evacuation missions. Now, obviously, they were flying into active fire zones, so the risk was understood as a tactical necessity. But when that model translated to civilian trauma use, it sparked a massive explosion of helicopter EMS, or EMS.
Right. Everyone wanted a helicopter.
Exactly. By 2017, we had over 1,400 registered air medical aircraft in the U.S., and the source data highlights that in one recent period, 217 people died in 81 fatal civilian EMS helicopter crashes.
That is just unacceptable.
In 2008 alone, we saw 28 fatalities. We were actively risking the lives of flight nurses, paramedics, pilots, and the patients themselves, all to save minutes that the data suggests may not have mattered for the vast majority of those transports.
And, it isn't just the aeromedical side either. Ground transport introduces this massive, often completely under-discussed public health risk. The source cites a deeply concerning 10-year retrospective study conducted by the National Institute for Occupational Safety and Health, NIOSH.
Yeah, the NIOSH study.
They analyzed 300 fatal ambulance crashes, and the body count is sobering. 27 EMS workers, 55 other ambulance occupants, and 275 pedestrians or occupants of other vehicles perished.
That's incredible.
That is over 350 deaths essentially caused by the delivery mechanism of trauma care itself.
And we really have to look at the etiology of those ground fatalities to understand the systemic failure here.
Yeah.
If you look at the Federal Aviation Administration data, they attribute up to 80% of aircraft accidents to pilot error. In the NIOSH ambulance study, a shocking 60% of the fatal crashes were due to driver error.
60%?
Yeah. It is the adrenaline, the cognitive load, the perceived absolute necessity for rapid transport driven by that golden hour dogma.
Right. I have to get there right now or they die.
Exactly. And the true statistical shocker from that NIOSH data focuses on the biomechanics of the crash itself. 40% of the ambulance occupant fatalities were riding in the rear patient compartment, and the vast majority of them were completely unrestrained at the moment of impact.
Right, because they're actively trying to fix the physiology while completely ignoring the physics of their own environment.
Yeah.
You have paramedics standing up in the back of a metal box that is moving at 80 miles per hour through red lights, trying to secure an airway or push a drug.
It's a recipe for disaster.
It is. So the ultimate question for us as scientists is, does the time actually matter enough to justify this level of systemic risk? I mean, if we accept the inherent morbidity of high-speed transport, the survival benefit must be statistically incontrovertible.
And that is the crux of the issue. A massive observational study analyzed in the text challenges that premise entirely. This study looked at 146 different EMS agencies, incorporating both air and ground transport, and evaluated 3,656 severe trauma patients. These were transported to 51 U.S. and Canadian-level IM2 trauma centers.
We really need to define severe here so you, the listener, understand the cohort. These were not like isolated extremity fractures. The inclusion criteria required a systolic blood pressure less than or equal to 90, a Glasgow Coma Scale score less than or equal to 12, a respiratory rate less than 10 or greater than 29, or the need for an advanced airway intervention.
These are the sickest of the sick.
Exactly. The exact physiological profiles that the golden hour is theoretically supposed to protect from irreversible shock.
And the median times broken down in the study reflect a really highly functioning EMS system. They had a 4-minute response time, a 19-minute scene time, and a 10-minute transport time. That results in a median total out-of-hospital time of 36 minutes.
That's incredibly fast.
It is. So the researchers performed complex regression analyses across all variations of time in this massive data set.
Yeah.
And the finding, they found absolutely no mortality difference based on pre-hospital times.
Not at all.
None. Zero. Furthermore, these findings persisted regardless of the mode of transport, regardless of the level of the first responding EMS provider, whether it was basic or advanced life support, and regardless of patient age or the mechanism of injury.
Wow, a completely flat line on the mortality curve, regardless of the clock. But hold on, let's put our methodological critique hats on for a second.
Let's do it.
Whenever I see a massive study that claims no difference in an inherently chaotic, heterogeneous environment like pre-hospital trauma, I immediately look for confounding variables. Because you cannot ethically randomize major trauma patients to a slow transport arm.
Obviously not.
Right. So is this just massive selection bias masking the reality?
And that is the required analytical step. Because this was an observational registry study. We have severe inherent confounding factors. For instance, EMS crews tend to scoop and run with patients who look like they're actively dying.
The classic load and go.
Exactly. They minimize scene time to almost zero. Conversely, they might stay longer on scene to package a patient who appears slightly more physiologically stable, even if their vitals technically meet the study's inclusion criteria.
Ah, I see.
This creates a paradigm where the shortest transport times might be heavily populated by the most devastating, completely non-survivable injuries, and that would completely mask any survival benefit of the speed. It's the dead-on-arrival confounding factor.
Right. If the 15-minute transport group is entirely made up of massive crush injuries, decapitations, and devastating penetrating brain trauma, well, their mortality will be near 100% regardless. So it makes it look statistically like speed didn't help.
Exactly.
But still, the sheer volume of patients, over 3,600, suggests that for the broad swath of severe physiological derangement, shaving 5 minutes off the transport time does not magically reverse cellular hypoxia or prevent the onset of coagulopathy. We really have to separate the epidemiology of blunt force trauma, where time matters slightly less, from penetrating torso trauma, where time is literally everything.
To really understand that heterogeneity, we have to look at how the epidemiology of trauma mortality has fundamentally shifted over the last 40 years. Back in 1983, Donald Trunke published his seminal paper describing the trimodal distribution of trauma deaths.
Oh yeah, a paper every surgical resident is tested on.
Absolutely. You had immediate deaths on scene from massive neurological or vascular disruption, early deaths within a few hours from hemorrhage, and late deaths days or weeks later from sepsis or multi-organ failure.
Right.
But modern data, specifically the comprehensive work by Dunst et al., demonstrates that we have shifted to a bimodal distribution. We've nearly eliminated that third peak of late deaths.
Which is amazing.
It is. And it's thanks to the advancements in your surgical ICUs. Better ventilator management, targeted antibiotics, goal-directed damage control resuscitation. Right. But the early death peak has shifted significantly as well. Trunke's early death peak was around 120 minutes. Gunst's modern data shows the median time for early deaths has shifted left to just 52 minutes.
52 minutes.
And the patients in that study were arriving at the trauma center at a median time of 42 minutes from the time of injury.
Okay, so if the median arrival is minute 42 and the median early death is minute 52, that gives the receiving trauma surgeon exactly 10 minutes to transition the patient to the bed, identify the primary lesion, establish massive transfusion protocols, and get absolute surgical control of the bleeding.
That 10-minute window is the modern reality. And in that highly specific context, the patient with active, non-compressible surgical hemorrhage, like a shattered spleen, a major liver laceration, or an unstable pelvic ring fracture of the golden hour, is unequivocally real.
Absolutely.
For a patient exsanguinating internally, no pre-hospital intervention, no matter how advanced, replaces the operating room. The text is very clear that for these actively bleeding injuries, rapid transport and definitive surgical treatment are the only path to survival.
It's the ultimate nuance for the clinician. Time doesn't matter for everyone, but for the patient bleeding into their abdomen, time is the only thing that matters. Helicopter transport might save minutes in transit, but waiting for the helicopter to spool up, fly to the scene, land, package the patient, that might actually cost critical minutes compared to a ground unit that is already loaded and moving.
Yeah, you have to do the mental math on the fly.
Right. The takeaway for you, the surgeon receiving these patients, is that the dogma of speed must always be weighed against the mechanism of injury. A delay in transport for a traumatic brain injury patient to secure a definitive airway. That might be life-saving. A delay for an actively bleeding, penetrating torso trauma to try and start an IV. That is universally lethal.
Which leads us perfectly into the next critical area of analysis. Because if we accept that blindly rushing every single patient is not the cure-all, and that waiting for a helicopter can sometimes be detrimental, we have to deeply scrutinize what the EMS crew is actually doing to the patient during that transport time.
Yeah, and historically, the most common, almost reflexive intervention performed by paramedics in the back of that ambulance was slamming fluids. Specifically, the old ATLS doctrine, the ubiquitous 2-liter bolus of lactated Ringer's solution, or normal saline.
The standard protocol.
Let's trace the genesis of this. Why did dumping 2 liters of room temperature salt water into a bleeding patient ever make clinical sense?
Well, the rationale was rooted in early animal models and a really profound physiological fear of end organ ischemia. In the early 1990s, laboratory studies on swine suggested that while aggressive saline resuscitation did increase the total volume of blood lost from a standardized injury, the overall mortality rate in those specific highly controlled animal models was not significantly affected.
Plus, the neurosurgical community was absolutely terrified of secondary brain injury.
Right.
The prevailing dogma was that any period of hypotension in a patient with a traumatic brain injury would lead to diffuse cerebral ischemia, exacerbating the secondary injury cascade. We were taught to artificially prop the blood pressure up at all costs to maintain cerebral perfusion pressure.
The overarching mindset was simply fill the tank. The American College of Surgeons Advanced Trauma Life Support historically advocated a routine 2-liter bolus of crystalloid as a starting point for any shock state. And this doctrine was adopted wholesale into the pre-hospital environment.
But EMS providers had very few options for monitoring the adequacy of that resuscitation. I mean, they didn't have arterial lines, they didn't have point-of-care lactate, and they certainly didn't have thromboelastography.
No, they had a basic blood pressure cuff.
Exactly.
So the goal became normalizing the vital signs, chasing a systolic of 120 millimeters of mercury with bags of crystalloid.
And we now know that was a catastrophic systemic error. The reversal on this data is one of the most profound paradigm shifts in modern trauma surgery.
It really is.
The text brings in a massive 2011 National Trauma Data Bank, or NTDB, retrospective review. And the findings were entirely paradoxical to everything taught in the 90s.
Yeah, the NTDB review demonstrated that trauma patients who received a pre-hospital intravenous line and subsequent fluid resuscitation had a significantly higher mortality rate than those who received no fluids at all.
That is wild.
The intervention designed to save them was statistically associated with killing them.
And this wasn't just like a slight bump in the p-value. The increase in mortality was incredibly pronounced in specific cohorts. It was worse in hypotensive patients. It was much worse in penetrating trauma. And for those patients with severe traumatic brain injury, the exact group we were aggressively slamming fluids into to protect their cerebral perfusion, the NTDB data showed a massive 34% increase in the risk of death.
Now, from a methodological standpoint, we must acknowledge the limitations of using a retrospective registry like the NTDB.
Right.
There's always the argument of selection bias. The classic critique is that EMS crews only took the time to establish IVs and push fluids in the patients who were visibly sicker, hypotensive, and closer to death, thereby skewing the mortality data against the intervention.
The sick patients get more interventions bias. If they code, you drill an intraosseous line and push fluid so the fluid looks like it correlates with death.
Exactly. But the text stresses that the researchers utilize complex propensity matching to adjust for injury severity. And this increase in mortality was seen across nearly all subsets of patients. It wasn't isolated. It was a highly robust finding. Low injury severity patients didn't show a difference, but in the critically injured, the harm was undeniable.
Let's break down the cellular pathophysiology for a second. Because as a trauma surgeon, you know exactly what a patient looks like when they roll in after receiving 3 or 4 liters of pre-hospital crystalloid.
They look terrible.
They are cold, they are oozing from every puncture site, and their tissues are physically weeping. Why does crystalloid kill the bleeding trauma patient?
Well, it rapidly accelerates a trauma triad of death, primarily through trauma-induced coagulopathy, or TACAC. First, you have dilutional coagulopathy. When a patient bleeds out whole blood, they are losing red cells, plasma, and platelets. When you replace that volume with normal saline, you are diluting the remaining already depleted clotting factors to the point of functional incompetence.
Right. And second, there's the mechanical aspect. You are physically dislodging established clots. The body's natural defense to penetrating hemorrhage is to vasoconstrict and form a fragile fibrin plug.
Exactly.
If you rapidly infuse 2 liters of fluid and artificially spike the hydrostatic pressure in that vessel, it's Laplace's law in action. You increase the radius of the vessel and the transmural pressure, and the wall tension overcomes the tensile strength of the clot. You literally pop the clot and restart catastrophic arterial hemorrhage.
Third, and critically, you induce severe iatrogenic hypothermia. Pre-hospital fluids are rarely warmed effectively. Pushing liters of room temperature fluid into a shocky patient drops their core temperature.
Oh, massive.
And the enzymatic reactions of the coagulation cascade, specifically the serine proteases like factor Ia and Za, are highly temperature dependent. If the core temp drops, those enzymes are functionally paralyzed. Even if you, the surgeon, give fresh frozen plasma in the trauma bay, those exogenous factors will remain completely inert until you can correct the patient's temperature.
And finally, crystalloids just have terrible intravascular retention. Within 30 to 45 minutes, 70 to 80% of that saline has third spaced into the interstitial tissues.
Right into the lungs.
Yeah, this leads to massive pulmonary edema, making ventilator management an absolute nightmare. It also causes severe interstitial edema in the gut bowel wall, which is a primary driver of the massive abdominal compartment syndrome that surgeons are forced to deal with when they try to close the fascia after a damage control laparotomy.
So the old protocols drove us off the physiological cliff. What are the new guardrails?
Yeah, how do we translate this into actionable protocols for our pre-hospital teams? And what should the receiving surgeon expect when taking a handover today?
The paradigm has completely shifted to permissive hypotension or delayed resuscitation. The goal is no longer a normal blood pressure. The goal is barely adequate end-organ perfusion while strictly minimizing clot disruption. The American College of Surgeons ATLF-10 has drastically altered its guidelines, limiting the initial suggested crystalloid volume to just 1 liter. And even that is to be given with extreme caution and constant reassessment.
The military has pushed it even further, which, makes sense given their austere constraints. The U.S. Department of Defense Tactical Combat Casualty Care, or TCCC, 2019 guidelines are now the undisputed gold standard for austere trauma management.
They really are. And under TCCC 2019, if a trauma patient is not in shock, they get 0 intravenous fluids, period.
Wow.
0.
0.
If they're in uncontrolled hemorrhagic shock, the target is purely clinical. The return of a palpable radial pulse or target systolic blood pressure of 80 to 90 millimeters of mercury.
We still have to respect the brain, though. For a patient with a suspected traumatic brain injury, the target is slightly higher, a systolic of 90 to 100 millimeters of mercury to ensure adequate cerebral perfusion pressure, but we are definitely not chasing 120.
And the delivery method has changed entirely too.
Yeah.
No more wide-open, gravity-fed IVs. The recommendation is small, targeted 500 milliliter boluses, reassessing the radial pulse after each one. But the biggest shift is the fluid of choice.
Right.
Crystalloids like lactated ringers, normal saline, and plasmolite A are heavily deprioritized. The absolute preference, whenever logistically possible, is blood product resuscitation, ideally low-titer O-positive or O-negative whole blood, or a 1-to-1-to-1 ratio of plasma, platelets, and packed red blood cells.
We are going to dive deep into the logistics of pre-hospital blood in our Q&A segment later on, because that truly is the frontier. But the clinical takeaway here is that if a patient arrives in your bay normotensive after receiving liters of clear fluid, you shouldn't be relieved. You should be absolutely terrified of their coagulation profile. The practice of administering crystalloid to achieve normal vital signs must be abandoned.
It is an artifact of the past, and it directly complicates your surgical intervention.
Okay, let's follow the clinical logic here. We've fixed the pipes by severely limiting bad fluids and preventing the popping of clots. But trauma isn't just about exsanguination. We must also protect the bellows, the pulmonary system.
Right.
This brings us to a classic pre-hospital challenge that every surgeon has managed the terrifying aftermath of: the traumatic pneumothorax.
The vast majority of traumatic pneumothoraces, simple lung collapses from rib fractures or penetrating trauma, never actually progress to a life-threatening tension pneumothorax. But when a one-way tissue valve forms and they do tension, the physiological collapse is incredibly rapid.
It's scary fast.
Yeah. As intrathoracic pressure builds, the mediastinum shifts. The superior and inferior vena cava are compressed. Venous return to the right heart is choked off. Right ventricular filling pressures plummet. and the patient goes into obstructive shock and codes. EMS personnel must be prepared to decompress the chest immediately to restore that venous return.
So historically, how was this handled in the field? EMS basically used whatever they had in their jump bag, and usually that meant grabbing a standard 14-gauge intravenous catheter, the exact same short plastic catheter they used to start an arm IV, and plunging it into the patient's chest.
Intuitively, it seems like it should work. It is a large bore needle. The problem lies in the basic geometry of the human body and the physics of Poiseuille's law regarding catheter length and radius. The historical dogma was to insert this needle at the second intercostal space in the midclavicular line. But standard 14-gauge FOVI catheters are usually only about 5 centimeters, or roughly 2 inches long.
And this is where the Inaba CT study comes in. This is one of my favorite pieces of trauma literature because the methodology is so elegantly simple, yet the findings completely upended a global standard of care. Dr. Kenji Inaba and his team at USC didn't just guess at why these needles were failing, they looked at the actual measurable anatomy.
It is a brilliant example of using modern radiological imaging to answer a basic functional anatomical question. Inaba et al. Utilized CT imaging to calculate the exact chest wall thickness of trauma patients, and then critically, they validated those measurements with cadaveric studies. They specifically measured the chest wall at the traditional insertion site, the second intercostal space, mid-clavicular line.
Let's look at what they found. The mean chest wall thickness at that exact spot was 45 to 46 millimeters.
Do the math on that. You have a 5 centimeter or a 50 millimeter needle. You have a 46 millimeter chest wall. That leaves you exactly 4 millimeters of clearance to penetrate the parietal pleura and enter the thoracic cavity.
4 millimeters, a fraction of an inch, and that's just the mean. If the patient has large pectoral muscles or is obese, or if the paramedic inserts the needle at even a slight downward angle instead of perfectly perpendicular, you never reach the pleural space.
Exactly.
Or perhaps worse, you barely reach it, and the moment the patient shifts during transport or the ambulance hits a bump, that flimsy 4 millimeter tip pulls out, the plastic kinks in the subcutaneous fat, and the tension physiology immediately returns.
The statistical reality of this anatomical mismatch was shocking. Inaba's data demonstrated that using a standard 5 centimeter needle at the second intercostal space yielded a massive 42.5% failure rate.
That is essentially a coin flip. We were relying on a primary, life-saving temporizing intervention that failed nearly half the time simply because the plastic was too short for the human body.
So, Inaba's team looked for a better anatomical solution. They measured the chest wall thickness at the fifth intercostal space, at the anterior axillary line, the lateral approach, roughly where you would place a surgical chest tube. The mean tissue thickness there was only 32 millimeters.
That's a huge difference in margin of error.
Approaching the pleura from this lateral site with the same needle provided a 100% penetrance rate in their models.
This data was unignorable. It was a direct catalyst for changing global protocols. The TCCCC 2019 guidelines and subsequently most civilian EMS systems mandated two major practice changes. First, they authorized the lateral approach at the fifth intercostal space. Second, and more importantly, they threw out the IV catheters.
Thank goodness.
The new standard requires commercially available, specifically designed decompression needles that measure 8 centimeters or 3.25 inches.
These 8 centimeter needles not only provide the necessary length to clear even a highly muscular or obese chest wall at the anterior site, but they are engineered to be kink resistant. They don't bend and occlude in the muscle fascia like pliable VAV catheters do.
As the receiving surgeon, this directly impacts your operative planning. If you look at the patient and see a short, pink 14-gauge 4V catheter in their anterior chest, you must assume it has failed or is about to fail and prepare for immediate scalpel thoracostomy.
Yep.
Conversely, if you see that rigid 8 centimeter dart placed laterally in the fifth intercostal space, you have to realize it might be sitting right where you want to place your definitive 36 French surgical chest tube. You need to mentally adjust your surgical approach and insertion site before you even gown up.
And there is one more critical clinical pearl regarding chest decompression mentioned in the text. In the terrifying scenario of traumatic cardiac arrest, where a tension pneumothorax might be the primary cause of the obstructive shock or a major exacerbating factor, standard protocol should dictate empirical bilateral needle decompression immediately.
Immediately.
Do not wait for portable chest x-rays. Do not wait to auscultate diminished breath sounds in a noisy trauma bay. If they arrest from blunt or penetrating trauma, decompress both sides of the chest.
It's the ultimate nothing to lose intervention. Okay, so we've resolved tension physiology, we've optimized the bellows. Now we move to the most visually dramatic, chaotic aspect of pre-hospital care, exsanguinating hemorrhage. Tension is resolved, but now we have to deal with the bleeding. Here's where it gets really interesting. We were talking about tourniquets and the incredibly complex debate surrounding tranexamic acid, or TXA.
Tourniquets have a fascinating, almost cyclical history in the surgical literature. The text credits Ambrose Paré, the legendary 16th century French surgeon, with the first use of the word tourniquet, though the concept of constricting a limb to stop bleeding dates back to the Bronze Age in ancient Rome.
But for the vast majority of our modern careers, what were we explicitly taught in medical school? We were taught that tourniquets were the absolute instrument of the devil.
Oh yeah,
The prevailing dogma was life over limb, meaning if you put a tourniquet on, you were accepting that the limb would inevitably be amputated due to irreversible ischemia. EMS was taught to use bulky dressings, elevate the limb, aggressively compress pressure points, literally anything but a tourniquet.
that dogma was deeply rooted in a misunderstanding of the equipment being used. The tourniquets of a few decades ago were terrible. They were often just narrow surgical rubber tubing or wide rubber bands improvised in the field.
Exactly like the venous constricting bands we use to draw blood in the lab.
And if we look at the physics of that, what happens when you wrap a narrow rubber band tightly around an arm? You generate enough pressure to occlude the low-pressure venous outflow, but the pressure is not nearly high enough to occlude the high-pressure arterial inflow.
It's a one-way valve for disaster. Arterial blood continues to pump into the limb, but it cannot escape through the venous system.
The result was explosive iatrogenic compartment syndrome. The bleeding actually increased, interstitial tissue pressure skyrocketed, and severe tissue ischemia and nerve compression resulted because the mechanical pressure was concentrated over a tiny, narrow surface area. They were incredibly painful, highly dangerous, and often worsened the hemorrhage they were meant to stop.
Contrast that with modern engineered tourniquets like the Combat Application Tourniquet, the CAT, or the Special Operations Forces Tactical Tourniquet, the SOFT TT. They are wide, at least 1.5 inches, distributing the pressure evenly across the tissue. And crucially, they utilize a rigid windlass mechanism.
That windlass is key.
Right. This allows the provider to titrate the mechanical advantage to reach true supraarterial pressures, completely shutting off arterial inflow.
The data from recent military conflicts completely shattered the anti-tourniquet dogma. A retrospective review of U.S. military Special Operations Forces deaths revealed a heartbreaking statistic. 13% of potentially preventable deaths on the battlefield were due to extremity hemorrhage that was entirely amenable to tourniquet control.
We were losing soldiers to arm and leg wounds because medics were afraid of the tourniquet dogma.
When they finally deployed modern windlass tourniquet en masse, the results were astounding. The text cites a specific, pivotal study from Operation Iraqi Freedom, or OIF. They looked at 67 patients who had pre-hospital tourniquets placed for an average duration of 70 minutes. More than half of these severely injured patients had improved, verifiable, life-saving hemorrhage control.
And the most important metric regarding the old ischemia dogma: zero limb loss attributable to the tourniquet itself. The fear of irreversible ischemia was vastly overstated for transport times under 2 hours. The muscle tissue is incredibly resilient to temporary ischemia if the arterial flow is completely stopped rather than partially occluded.
This military success directly translated to civilian streets. The National Highway Transportation Safety Administration, NHTSA, completely revised the pre-hospital scope of practice in 2019. EMS stopped the endless, futile cycle of adding more bulky dressings to massive arterial bleeds. They added aggressive wound packing with hemostatic gauze and immediate tourniquet application. The American College of Surgeons launched the massive Stop the Bleed campaign in 2017, bringing this life-saving knowledge to the general public.
While civilian survival benefit data is still maturing, the military literature is unequivocal. Modern tourniquets are safe, highly effective, and the retention of application skills by even non-professional laypersons is highly encouraging.
But tourniquets only work on arms and legs.
Right. What about the guy shot in the abdomen? What about the ruptured spleen or the shattered pelvis? We can't put a tourniquet around the patient's neck or torso. For non-compressible torso hemorrhage, we enter a heavily debated pharmacological arena. We need to talk about tranexamic acid, or TXA.
TXA is a synthetic, lysine analog antifibrinolytic agent. Simply put, it stops the body from breaking down the clots it has already formed by competitively inhibiting the activation of plasminogen to plasmin. In the pre-hospital setting, where you cannot mechanically stop internal bleeding, pharmacological stabilization of the clot seems like the ultimate solution.
Wait, let me stop you there. The initial data was incredibly promising. The CRASH-2 trial, which was this massive international study of over 20,000 trauma patients, and the Military Matters study both showed a definitive survival benefit for trauma patients receiving TXA. The number needed to treat was impressive. So if CRASH-2 showed a survival benefit, why wouldn't I want my paramedics pushing it on every single hypotensive trauma patient? A 1-gram bolus is dirt cheap. What's the actual harm if they guess wrong?
To understand the harm, we really have to look at the specific dosing and the severe time constraints. The evidence-based dosing regimen derived from those studies is a 1-gram bolus given over 10 minutes, followed by a second 1-gram continuous infusion over the next 8 hours in the ICU. The critical, unyielding time window is that the first dose must be administered within 3 hours of the injury. If given after 3 hours, the data suggests it may actually increase mortality.
A 2019 literature review by Stansfield et al. Concluded that this exact regimen produced the best outcomes and supported the safety and feasibility of EMS crews pushing TXA in the field during transport. So again, a cheap drug that saves lives. Why the controversy among U.S. trauma surgeons?
Because the coagulation cascade is not a monolith. Not every trauma patient is bleeding the same way at an enzymatic molecular level. This raises an incredibly important question. What if the patient isn't breaking down clots too fast? What if their body has naturally shut down the clot breakdown process to protect itself?
And this is where we get into the brilliant work by Dr. Ernest Moore and his team in Denver, utilizing thrombolithography, or TEG. TEG doesn't just measure if blood clots like a standard PT or INR test. It measures the viscoelastic strength of the clot and exactly how fast it breaks down over time.
Moore et al. Demonstrated that trauma patients fall into distinct coagulation phenotypes based on their TEG profile. Some are in hyperfibrinolysis. Their clots are dissolving way too fast due to an overabundance of tissue plasminogen activator, or TPA. These patients desperately need TXA. Some are in physiologic fibrinolysis, a normal, balanced state. But a highly significant subgroup is in what is known as fibrinolytic shutdown. Their bodies have completely inhibited fibrinolysis, likely through elevated levels of plasminogen activator inhibitor 1 to conserve whatever clots they have left.
Think of the patient's coagulation system like a retaining wall holding back a flood. Giving TXA to a patient in fibrinolytic shutdown is like pouring concrete onto a retaining wall that is already completely solid. You aren't stopping a flood, you're just creating a massive, immovable blockage that's going to cause a catastrophic pulmonary embolism in my ICU a week later.
You severely exacerbate the shutdown. You push them into a violently hypercoagulable state. Moore's analysis suggests an increased mortality in patients with fibrinolytic shutdown who receive antifibrinolytic agents. They survive the initial hemorrhage, but they die days later from massive deep vein thrombosis or microvascular thrombosis leading to irreversible multi-organ failure.
And therein lies the fundamental problem for EMS. The pre-hospital provider cannot run a delicate, vibration-sensitive TEG machine in the back of a bouncing ambulance.
It's impossible.
They cannot identify which molecular phenotype the patient is in. Therefore, field administration of TXA remains a blind, protocol-driven intervention.
It requires extreme judicial use. The current consensus, carefully balancing the CRASH-2 data against the TEG phenotype concerns, is that pre-hospital TXA can be considered in hypotensive trauma patients with suspected non-compressible torso hemorrhage, provided it is well within that 3-hour window.
But there is a massive caveat, and this is a vital clinical pearl for the listening surgeons. You must exclude isolated extremity injury.
Absolutely. If the bleeding is purely from an arm or leg, it should be controlled mechanically with local wound packing or a tourniquet. Do not give systemic TXA for an isolated extremity bleed. Why? Because you, the surgeon, are going to have to take that patient to the OR and perform a delicate peripheral vascular repair, perhaps a saphenous vein interposition graft to save the limb. If the patient has been loaded with a systemic, highly thrombogenic agent like TXA, the patency of your microvascular anastomosis will be severely compromised. You will be fighting microscopic clotting in your surgical field for hours.
Okay, we've established that blind TXA is dangerous because we can't see the coagulation phenotype in the field. So if we can't safely manipulate the patient's existing blood with drugs, how far are we from just giving them new blood? Let's talk about the logistical nightmare of field refrigeration and look toward the horizon of U.S. clinical practice. I want you to translate these pre-hospital innovations to what the trauma surgeon can expect to see in the Bay in the next 5 to 10 years.
The ultimate goal is whole blood in the field. But as you mentioned, whole blood requires massive logistical oversight, specifically uninterrupted refrigeration. Ambulances are essentially hot boxes in the summer and freezers in the winter. They are not equipped with sophisticated, monitored blood banks.
So how do we get clotting factors, plasma proteins, and volume into patients in the dirt without refrigeration? Tell me about the resurgence of freeze-dried plasma, or FDP.
Freeze-dried plasma is exactly what it sounds like. It is plasma that has been lyophilized, freeze-dried in a vacuum into a stable, shelf-stable powder. It can be carried in a medic's backpack in the desert at 100 degrees. You simply reconstitute it with a bag of sterile water, mix it, and inject it. It sounds like modern science fiction, but the history of FDP actually dates back to World War II. It was widely manufactured and used by several countries, including the US, France, and Germany, to save countless lives on the battlefield.
If we had it in 1944 and it worked, where did it go? Why isn't it in every ambulance in America today?
It was banned by regulatory agencies. With the advent of better virology in the mid-20th century, the medical community recognized the severe risk of pathogen transmission, specifically the transmission of hepatitis B and C from pooled, unpurified plasma products. The U.S. Food and Drug Administration completely withdrew FDP from use in 1968. It essentially disappeared from the American medical arsenal for decades.
But war is always the mother of medical invention.
With renewed military activity during the Gulf War, and subsequently the prolonged conflicts in Iraq and Afghanistan, the military demanded a solution for austere, far-forward hemorrhage control. Production resumed, but this time utilizing modern pathogen-reducing techniques. Specifically, they employ solvent and detergent washing, which safely and effectively neutralizes lipid-enveloped viruses, completely eliminating the hepatitis transmission risk that plagued the World War II-era products.
So the military drove the innovation, and now we're seeing the fruits of that labor.
The French Military Medical Service has been leading this modern charge. Their manufactured version of FDP, known as FLIP, was actually approved by the FDA in 2018 under an emergency use authorization specifically for the U.S. military when standard fresh frozen plasma is unavailable in austere environments.
But it's not in civilian hands yet. I can't stock my local EMS agencies with it.
Not quite yet. Broad civilian use, including standard EMS and even emergency departments, has not been fully approved, though advanced phase trials are underway. Bringing it to the civilian market is a regulatory and logistical mountain. Conducting the clinical trials, designing the right reconstituting containers for the back of an ambulance, securing massive amounts of raw plasma for lyophilization, and figuring out the complex reimbursement models for pre-hospital agencies.
But if we connect this to the ground truth of modern resuscitation, the promise of FDP is undeniable. We know from massive trauma trials, specifically the PRM-MMTT study, the Prospective Observational Multicenter Major Transfusion Study, and the PRO-PPR randomized clinical trial, that there is a definitive, undeniable survival benefit associated with high plasma to red blood cell transfusion ratios.
The early aggressive use of plasma is firmly supported by the highest levels of trauma science. It replaces depleted clotting factors, restores intravascular oncotic pressure far better than crystalloid, and uniquely reverses the devastating endotheliopathy of trauma by repairing the endothelial glycocalyx layer. FDP could revolutionize civilian EMS by entirely bypassing the refrigerator. It would allow paramedics to initiate true damage control resuscitation at the exact point of injury, fundamentally changing the patient's coagulation profile before you ever lay eyes on them.
So what does this all mean? We have covered immense ground today.
It means the evolution of pre-hospital trauma care is accelerating at a breakneck pace. We have transitioned from a panicked, blind rush against the clock, where we drowned bleeding patients in 2 liters of room-temperature salt water, to an era of precise, molecularly aware, lesion-specific care. We now understand that permissive hypotension protects fragile clots. We know that 8-centimeter needles are anatomically and geometrically necessary to defeat tension pneumothoraces. We know that wide, mechanical windlass tourniquets save lives without sacrificing limbs. Street-level EMS professionals are performing highly sophisticated evidence-based iterations of care that directly impact survival.
And for you, the trauma and surgical critical care surgeon listening, understanding these pre-hospital dynamics is no longer optional reading. It is the mandatory first step of your operative plan. You have to speak the language of the paramedics. Whether it is looking closely at the exact length of the decompression needle sticking out of a patient's chest to determine if you need an immediate scalpel thoracostomy, or quantifying the exact amount of crystalloid they received before the handoff to anticipate bowel edema during your fascial closure, or knowing if they received a blind dose of TXA in the field that might ruin your vascular repair. These variables directly dictate your surgical strategy, your your anesthesia considerations, and your massive transfusion protocols the very moment that patient arrives. You cannot manage the physiology in the OR if you do not understand exactly how it was manipulated on the street.
It's all connected.
It is. I want to leave you with a final, provocative thought. Something to mull over on your drive home or before your next 24-hour call shift. We are rapidly moving toward pre-hospital whole blood products. We are already seeing the deployment of point-of-care ultrasound, or PERSIS, in the hands of advanced paramedics. We are actively discussing the eventual reality of freeze-dried plasma and perhaps even field miniaturized TEG capabilities. As the technology shrinks and the protocols become exponentially more sophisticated, how long until the back of the ambulance essentially becomes the first trauma bay? And if we can initiate definitive, balanced blood resuscitation, identify internal cavities with ultrasound, and achieve temporary hemorrhage control at the exact point of injury, does the concept of pre-hospital care cease to exist entirely, replaced by a seamless continuum of surgical resuscitation that just happens to start on the highway? Thank you for joining us on this deep dive. Stay sharp and trust the data.